healthcare voice of the New Right Network. This is Stealth on Health with Mario Nasinovich. Envisioned by the people, voiced by the people, powered by the people, it's everyday people with extraordinary values that make up the New Right Network. Welcome to the healthcare voice of New Right Network. This is Stealth on Health. I'm Mario Nasinovich. And joining me for episode number 13 is an incredibly knowledgeable and pioneering physician who's also a researcher and professor. He currently works as a senior staff specialist at Gold Coast Health and Hospital Services. He is an associate professor with Bond University School of Medicine in Queensland, Australia, and the head of the Kira Kira Clinical School in the Solomon Islands. Additionally, he serves as adjunct senior clinical research fellow at the Institute of Glycomics at Griffith University and part of the Medical Rescue Air Ambulance Retrieval. He has had a medical licensure on 3 continents, which we'll dive into a bit today, and he possesses his undergraduate degree in biology from the University of Scranton in Pennsylvania, his MBBS from the University of Queensland Graduate School of Medicine in Australia, and his Master's of Public Health from the Thomas Jefferson University College of Graduate Studies in Philadelphia, Pennsylvania. Welcome to the 13th episode of Stealth on Health, Dr. James Fink.
Thank you, Mario. It's a pleasure to be here.
Yeah. So, Jim, in 2019, the World Health Organization released a list of 10 threats to global health. And among these, somewhat prophetic, was the threat of a global influenza pandemic. What's been your firsthand experience about the pandemic? And tell us about your personal experience between the UK and Australia.
So myself and my family, we took the year, or the planned to be a year, into the UK, leaving here, Australia, July of 2019. It was going to sort of be a sabbatical year, and an opportunity to travel, let the girls have a different school setting and things like that. And I went over there with a contract to work in the NHS in Oxford. And so I was working in Oxford through the pandemic. That was my experience of it. I think that the world has seen sort of clusters of catastrophe in certain areas like London or New York, or unfortunately several areas in the US and northern Italy. Now, Oxford was not one of those places. It sort of had a steady supply of COVID cases. So there was plenty of exposure for me there in terms of the clinical experience. But it was never really overwhelming. I never felt like we had a major surge that stressed the system. We had about 100 inpatients in the hospital at any one time, plus 20 or 30 in the ICU. And being a general physician, hospitalist, internist, we were sort of right there on the front lines and dealing with most of the cases that were not requiring that critical care. So I feel like I got a lot of exposure to the COVID related issues without being overwhelmed, which unfortunately I think a lot of other places were.
So, World Health Organization thought that this potential threat of a global pandemic was one of the threats. You've been actively practicing medicine through the first 2 decades here in the 21st century. What additional health risks or concerns do you have?
Well, I think that probably, and unfortunately, we will continue to see pandemics. And I think some of that might be related to climate change and the movement of what were sort of diseases and or conditions that we might have only seen in warmer environments and things like that spreading more globally. I think that the interconnectedness of the world also adds to that. These are all things that have been said and discussed fairly frequently within the literature. So I think there's further issues with future pandemics. I think climate change related issues. And then I think that one of the other things that we'll be dealing with is just health systems and how they manage all of this. And that can go from health systems in low and middle income countries to even the wealthy places like the US or the UK, where I think this kind of thing exposed some of the weaknesses in those systems as well, which would have prided themselves on, their claims to excellence. I think Australia, where I have not been during the pandemic, they did some things very well. I think they also got lucky. But those are some of the things that I think will be part of the future that we face and need to deal with, as well as many others, I'm sure.
Absolutely. No, and that's certainly a great global perspective. What do you see as the greatest challenges facing the healthcare sector specifically, aka the business of healthcare? That is, the patients and what's happening with regards to care on a daily basis, the things that you think about as you're going to work every day.
Yeah, well, I think a lot of health systems have been stressed not simply by the pandemic, but by the need of patients and individuals seeking care.
Yeah.
And I think that what's been interesting and where I think that we see some hope for innovation and stuff is what we had to do related to the pandemic. So telehealth sort of was finally able to launch itself as
Like never before.
Exactly.
Yeah.
We had talked about it. We talked about it here in Australia. It had been talked about a lot in the U.S. That Jefferson, where I had formerly worked, I knew that they were making headway with it, but it wasn't until we had this happen and people said, we can't do things the old way. And we sort of were able to just sort of dispense with some of the rules that impede us, that we saw that sort of thing happen. So I think that we have opportunities based on what we've seen here. I think that, within the business of healthcare, I think there still needs to be that sort of balance of, we want to, and again, this is maybe something we can get into, is like, how do we balance the business of healthcare? There's things that we are able to do, and the question is, can and should we do those where in a system where we might not be able to give appropriate equity to all issues.
No, and that's a big challenge. We know the healthcare disparities, the social determinants of health. We know health equity is just a tremendous topic of conversation throughout the world. Certainly, your master's in public health, as well as the amazing work that you do in the Solomon Islands, speaks to some of these issues that happen in all populations. And we certainly will explore that a little bit more momentarily. But let's break down some additional challenges together, specifically in that business of healthcare, because these are things that, since your first day working as a physician, we haven't made a lot of headway in. And the first one I think about is, what can we do to finally address the burden of preventable medical errors?
Yeah, I think that's calling attention to it, as I think to err is human or something like that was the original article that came out about 2000 and scared everyone by reporting that we had nearly 100,000 deaths related to medical error. It's still a problem. I think that there's been a lot of effort to address it throughout hospital systems. And now maybe we've buried ourselves under too much bureaucratic burden trying to do that. So it's a hard one because I think that maybe we're in a position where we're having diminishing returns as we add more and more rules. And I think maybe one of the factors that is associated with that is just that healthcare, as many areas are, I guess, today, it's just such a rapidly changing area. So keeping up with the latest. Yeah. And I think that's where we're going to just need wise guidance. I mean, thousands of articles are published daily, right? And what from these are game changers? What are practice changers that we actually have to, pay attention to? Where's the best evidence to guide us in regards to patient safety, rather than just adding layers and layers of complexity? How do we kind of, reach that simplicity beyond the complexity that says these are the most evidence-based and or common sense management tools to prevent these errors? it's still an issue. I just hope that it's something that we're able to manage better in the next 5, 10 years, things like that.
And I certainly, with the evolution of some of these electronic health records and telehealth and some of these systems, it'll help. But in terms of what you just said before about the overwhelming amount of information that's available, we have literally and figuratively had a medical information explosion, not just in terms of peer-reviewed publications and clinical trials, but just information everywhere. And it seems at times that physicians as well as patients and their caregivers, they're drinking from a fire hose. It seems. Pros and cons of more information and being accessible to all the various stakeholders in the healthcare sector.
Yeah, I think that that's the pro, right? Is that we have more equity of voices in that space, and rather than just the voice of a doctor saying you will do this. I think
Right.
we've got a bit more uh, being said by all aspects of care, be that the business side and the executive side and the clinical side and on all of that, even the patient side, which we're certainly paying a lot more attention to. But I think that the problem is, drinking from the fire hose example that you've stated, and that it's so much, it's infobesity.
Yeah.
It's just we're overwhelmed, and we need to say, wait a minute, like, what of this, just like when you're a medical student, the medical student's question is, what do I need to know? What do I need to know for the exam?
Thanks for
And
all of this, but I want to know what I need to know about
yeah,
this.
yeah, okay, that's fine.
Yeah.
What's going to be on the exam?
Yeah.
And that's kind of what we need to think about. It's like, okay, we might have this kind of large base of information, but we need to sort of ascend that and say, there's pieces of this that are must knows and that we must use to contribute to our care. I think that's hard. I still remember one of the professors from medical school telling us, 4,000, new articles are generated within the medical field every day. And I think that number is probably doubled
Yeah.
now.
Yeah.
And it's kind of part of the currency of medicine and academia and the whole field of science, right? Publish or perish. But again, is this diminishing returns? I think it's nice to have a voice and to know that some little study went on over here that might guide someone
One
else's,
pebble on that giant boulder of knowledge. That yeah.
yeah, let's till that little patch of soil and see what else we can discover. But then there's really also just needs to be this kind of umbrella that says, if we're going to change management or care, what of these zillions of articles is really going to take us forward?
And what may be that part that's going to be on the test that's salient to everyone that's practicing medicine today?
That's right. And I think that with the, this is also something that's mentioned a lot in the healthcare, is this sort of tribalism, right? How do we tribes are good because I think that they can expand knowledge within their given areas. Tribalism is bad, right? Like if we cannot if we cannot come together and pool that information for improved, care and integration, then I think we're in big trouble.
And we're going to be talking about integrated care in just a little bit. So all of you who are tuning in to wonder what comes next, we'll also take a look back at some of the classic work that's been done in integrated care and some of the work done by Dr. Fink and some colleagues. But Jim, classically speaking, up until this moment in history, medical history, there's always been a very slow diffusion of medical knowledge. And there's been a test and learn mentality. We've seen an incredible increase in momentum. How do we continue to increase that momentum and overcome any barriers that exist in terms of the spread of knowledge? And when I say knowledge, I think you know what I mean there. It's the timely and relevancy of that knowledge, because certainly we can't look at everything that's going on. So how do we increase momentum? I think we're already started, certainly with everything coming out every day, news items, studies coming out every day during the pandemic. And what are the barriers in terms of that diffusion?
Here again, I think that the COVID pandemic has been an example, and there's lots being talked about here about dissemination of information, its rapidity, and its accuracy, and things like that. So we've seen during this COVID pandemic, the major journals publishing a lot of case
So fast.
studies, things like that, just trying to spread information that can be helpful to others facing the issues associated with COVID, and that's been a good thing. And yet there's also been a lot of caution that's been spoken about in that space, because if something goes to print, I don't think it needs to be interpreted as this is now an absolutely accurate way of dealing with things. It's just hey, heads up, this is what we saw and this is what we did, but it might need some more refinement. So I do think that what we've seen through COVID can help medical journals, things like that, medical information groups, to say maybe we can do this somewhat differently. But I also think that hopefully as we get over the COVID and we see what has happened with all this, we might also have some additional guidance about, okay, maybe we don't want to go at that speed, but sort of medium speed might be good, as opposed to glacial speed where we were operating previously. I don't know. I think that might be something that we're able to learn from this as well, using the COVID example.
Agree. And I'd like to switch gears a little bit and explore with you something that I personally have observed, certainly have heard a lot about as well, and have read regarding your colleagues literally all over the world. When I say colleagues, obviously I'm referring to physicians as well as other healthcare practitioners. Some have written that there is a collective uninspired voice of many physicians who, quote unquote, have lost their faith or interest in the work that they do. And certainly the risk is that, their voice will deter the intelligent, optimistic, blind youth that is looking to pursue this great work in this great field. You've worked, Jim, across Australia, the UK, and the US. Tell me about what you've observed in terms of the collective mindset historically with your colleagues, and where it is now. And is the statement largely true that people are kind of losing faith or interest in the field?
Yeah, this is, really important stuff, I think, for the future of the entire healthcare field. I think, well, let me say firstly, I think healthcare systems, and I have worked in three, survive on the goodwill of the staff working in them. Okay. A place like the UK, those doctors are not on big salaries. Everybody's working hard. And I have a number of colleagues who are over there in the US still, who I did my residency with. They are bright, they work their bums off, and they're amazing people. I also think that historically, and probably continues to this time, people went into healthcare basically because they kind of want to help people, right? I don't think that a lot of people go into healthcare thinking, I really want to make a lot of money, or I want to drive fancy cars. Yeah, there's good salaries and people can do those things as well. But I do think that there's a sort of desire to apply science to a human being and to try and do some good. The health systems and the work has gone in healthcare is that, there's been some of this loss of those things that inspire people to go into it, right? Autonomy and that feeling that you're a part of a sort of group and things like that, at the service of, kind of service delivery. And I think that as we've gone into where business has come into healthcare, as it should have, and as it will stay, some of that which leads to burnout and a loss of inspiration is that the doctors, nurses, healthcare workers in any way are there just doing the drudgery of sort of service delivery, and we've lost that kind of ability to say, we're actually doing some good here, which was a nice feature of all of this kind of clapping, maybe too much hero worship about all the doctors and things like that and nurses, but it was nice to see that. So I, I don't have a total loss of faith in terms of where it goes
That's
or
promising.
yeah, or who comes into medicine in the future. But I do think that, we've seen plenty of literature and issues associated with burnout. And I do think that these are going to need to be things that are addressed if we're going to maintain a pipeline. Are kind of my thoughts in that space. So
That's great. Yeah.
I think it's a issue across health systems. I think everybody, here in Australia, it's the same thing as the business of healthcare is faced with issues. We don't have enough money. We have too many patients. How do we get the flow right? How do we get the right patients coming to see those facilities and others just doing the GPs or staying at home? They're not easy answers to those things. But if all we do is continue to impose, rules and restrictions on the workers, you're just going to completely demotivate them.
Yeah. And that's a sad situation. We know, certainly over the last 2 decades, the prediction of all the shortages that we would be experiencing. And certainly I think right now is a very interesting time. We'll have to see how this plays out, whether we are going to be indeed having a shortage or we're just going to need to hire back a lot of those individuals that have been furloughed. So I think we've got a tricky situation at hand. We talked a little bit about how the three healthcare systems are alike, and we've highlighted some of those points. You've experienced three. How vastly different are they?
I mean, mostly they're similar in terms of, the people and patients that are being seen. I think that
People are people. We're all the same.
people are people. People get sick. I think that when earlier in my career, I was sort of thought to myself, why does everyone have to do stuff differently? Why can't we be more united? And I can see over time, certainly the benefits to looking at things slightly differently, and the fact that even though we think people are people everywhere and everybody's blood is red and things like that, there are slight differences, and maybe there's more than slight differences that require things to be looked at differently in their context of individual systems, countries, and things like that. I think that we have the UK system where we have the NHS, which serves most of the population's healthcare there. I think you might know this better than me, Mario, but it's only about 10%, maybe up to 20% that do private, care in the UK. Then we have, the US, which is a bit of a mix. There's certainly public type care, but most hospitals are private and everybody's trying to make a buck as well as provide appropriate care. And then there's the Australian model, which is a mix of, in the US, this term will get you in trouble, but that kind of socialist care, right? Sure. So there's a baseline of medical care here
That
provided.
everyone
receives, and it's called Medicare.
Yep.
And I think that's been going on since at least the late 70s, if not the early 80s. But so that will serve everyone in the population. But then there's a private healthcare system, and 50% of doctors work within both. And there's a lot, particularly of procedural specialties and things like that, surgeries. Almost 2/3 of it goes on in the private sector.
I believe it.
I think that, the care of patients in terms of medicines and or the surgery that's performed, and these are all very similar, but the way that they're done it within the business of medicine is where we see the differences and where I think nobody's got it right.
There's no
But
perfect system yet. Yet we're
no,
trying.
exactly. Yeah. But we should be open to the conversations about what works and what doesn't. So,
And one of those conversations is something that we have actually talked about quite a bit in all the years that we've known each other. That many of these health systems really continue to experiment with the best way to care for those patients. And these is a very unique area. Those who wind up in the hospital most frequently. So you and I have talked about integrated care, and for our viewers, can you share what this is and how it works?
integrated care is kind of an effort.
Oh,
Well,
you,
one, the word
a
itself,
movement?
integration is sort of like, okay, let's zip it all together,
Yeah.
right? Let's communicate better, let's coordinate our services better, and care for patients in that way better across the continuum of care, right? Not just I'm going to do the surgery or I'm going to fix this aspect and then I'm going to not think about it. Let's think about the entire journey.
Right.
So that's kind of integrated care. And then as you and I have talked about, I think there's been a lot of use of that term, and people don't always mean the same thing. I think
Right.
they come close in terms of what they're referring to, and then there's different approaches that people use in integrated care. But what people are trying to do is, sort of that the cost quality sort of triangle of how do we do this best for our patients is what integrated care is about.
Mm. Oh, it's fantastic. The amount of research that's gone on for literally the last 2 decades in this area, and so many different models being advanced and tried. You and I reviewed recent research about a very interesting group that you've had some access to as well, and these are called the super utilizers. Can you define this group for our viewers? And I think they'll be able to identify who these individuals are. They may be actually be in their own families.
Yeah, I mean, this is the pyramid of sort of healthcare, right? And at the bottom are healthy people, right? And as you ascend that pyramid, you sort of get those who are at risk for chronic illnesses or other issues, and then you come up slightly higher, and those who have stable, conditions. But at the peak of that pyramid, which might be about 5% of patients, these are the super utilizers. They have chronic, difficult to manage conditions, social determinant issues that make it all difficult for them. And that peak of the pyramid actually inverts. So even though it's 5% of the population, they use 50% of or more
Amazing.
of healthcare resources. So people are going, oh my gosh, how do we kind of deal with this? Because they are a burden of expense. They are hard for the healthcare systems to manage just in terms of time and things like that. So again, it's a efficiency and a quality issue for so many systems to say how do we better understand and how do we better manage this group of patients. And I think it doesn't matter again what system you're in. People are trying to figure this out, and no one's got the answer yet.
No, no. But we have seen some work that has been done, and you and I have talked quite extensively about this. For the folks that don't know and are starting to get a little bit of an understanding about integrated care and these individuals that are super utilizers, we're really talking about the sickest of the sick and people who have some unbelievable challenges physically, mentally, those social determinants of healthcare that you described. I'd like to pivot and talk a little bit about the timeline of events and the evolution of the models. And let's begin with Dr. Jeffrey Brenner. We've talked a lot about Dr. Brenner. He's a primary care physician who built the Camden Coalition. Tell us a little bit about what he was trying to accomplish.
Yeah, I mean, his was an effort to manage kind of this population of heavy utilizers, super utilizers, and knowing that, well, that's great. You can do what you can for them and manage them in the hospital.
Yeah.
But the only way you're going to prevent them from coming back to the hospital is to try and get out there and also help them deal with these social determinants. Are they taking their medications? Are they being monitored? What are their diets? What other issues are there for them? Do they have transportation? Do they have housing? All these sorts of things are being met.
Yeah,
So Hospital care, we know, is the most expensive care we can provide. If we can prevent them from coming there, we're going to save some money.
Yeah.
We should also be improving their health. So there was an effort by Brenner and his group down there in Camden to do a kind of an integrated care model, which says, okay, we're going to deal with the hospital issues, which include, social work, case management type of things. But then we're going to sort of bridge that into the community and try and follow this up closely through, nursing type visits, additional monitoring and stuff like that, and see if by doing that, we can prevent their rapid and frequent return to the hospital, where, as I said, we know we spend lots of money on them for what absolutely seems like a revolving door.
Yeah, and it's definitely, like you had said, it's the largest amount of spend for the smallest amount of people utilizing those services. We've talked about a recent study that's raised some questions about the program, specifically with those regards to those complex medical and social needs. What have we learned recently about this coalition?
Yeah, I think that the efforts of this Camden group were admirable, and I think early on,
Pioneering, dare we say?
yeah, I mean, and it met with a lot of excitement and enthusiasm, as it should have. But
And
I think
support.
that
I think that's a key thing here from an innovative standpoint. It received a lot of support to get done.
absolutely, and I mean, hospitals know this, right? They're like, how do we deal with this? Hospitals and health systems is, how are we going to deal with this group? And so, there was a money and enthusiasm and effort put behind it. But, I think it was only 6 months ago, it might be a little bit more, and then the New England Journal came out with their article and kind of said, maybe it didn't get across the line in the way that was anticipated early on. They didn't really have a control group. These were amongst the many issues. But even if there was an initial spike of improvement, then there was generally this kind of regression to the mean, which is the problem with a lot of these things, is that if we don't follow it out long enough, then we don't actually know. We might have this initial spike of enthusiasm and excitement, but we actually have to watch where that curve goes. Yeah. And in this case, that curve went back to, I don't think we really stopped a lot of this utilization that had been our part of our plan. Yes, and it's just a tough area. It's a tough area.
So we've talked about this together, and it's nice to observe what others are doing. But tell us a little bit about your work there on the Gold Coast with the Gold Coast Integrated Care GCIC program. And can you draw some parallels for us? How you sought to care for these patients who end up in the hospital most frequently?
Yeah, so ours was very similar, as far as I can tell, to what was going on in Camden. And these are efforts that are going on around the world. Everybody's trying to figure it out.
Everybody's trying to figure it out.
We had our go, and we spent 4 or 5 years, and a bit of resources and personnel, and we tried to do the same thing. Who are those super utilizers? How do we identify them? Can we kind of risk score them in regards to who we think might be coming back in the future, right? So one of the interesting things we did was kind of a hospital readmission score that looked at a number of different parameters to tell us who might be at risk for coming back. And then we also tried to put a package of care around these people and said, and again, just like the Camden thing, which was they might hit one, could we prevent them from hitting the hospital? That would be one thing, through better communication, coordination, things like that. But 2 was, if they hit the hospital, could we reduce their length of stay, get them back out to the community, and prevent another hospitalization? And we struggled. I think that, there's no 2 ways about it that I think we made great efforts. I think we did very well in sort of including a control group in our analysis.
So that was pretty landmark as well. I mean, that certainly.
Yeah. Yeah, I think we went into it with some real good ideas about, what we needed to do and show
Right.
that would truly prove if our model and our efforts worked. And
Hmm.
um, we had satisfaction improvements from patients, from the general practitioners, and things like that. But in terms of actually reducing admissions or reducing spending, we were not able to accomplish that in the 4 years of our study. So,
And certainly, you are no stranger to doing research. I want to talk a little bit about the latest research that I saw from you as well as several of your colleagues. You recently published a paper with colleagues on TB or not TB. I won't stand in judgment of the Shakespearean ripoff there, but
yeah.
the extended title was "Tell us about this TB treatment study that occurred in the Solomon Islands and any lessons learned from this, Jim, that may apply to what we're experiencing now with COVID-19."
Yeah, well, the Solomons is an interesting place, and a place that struggles a lot, right, with the what they call the triple burden of disease, right? So there's communicable diseases, non-communicable diseases, and then the threats of climate change, which are very real for them. I mean,
Very
they're
real.
actually, yeah, islands going underwater within that Solomon Islands
You know what,
chain.
Jim? I'd like to just take pause there and
Yeah,
interrupt you because maybe I jumped the gun a little bit to talk about the Solomon Islands and
yeah,
the TB work. We did talk about climate change earlier, and
yeah.
while that is a little bit of a foreign concept, unless people are going and seeing the effects on the ice sheets and
Mhm.
tracking temperature change and looking at water levels. But in the Solomon Islands, this is not something that is going to happen. This is something that's happening. So why don't we
Yeah.
focus on that just for a minute, just to give people perspective of what you've experienced firsthand there.
Yeah, I mean, the Solomons is a group of about 900 islands that's familiar to Americans from World War II, and Kennedy was there, and I think Nixon was also there during the battles of the Pacific. But yeah, it is a place where they are struggling with present effects of ocean level rise, and they're a place that is already struggling anyway with
Yeah.
economics, health, etc. But yeah, so there are islands that are and people's livelihoods that are starting to literally go underwater as the oceans rise there, and the seawater is kind of flooding into places. Where I go in Kira Kira, that is not really the major issue, but other things associated with, sort of heavy rains and the erratic nature of the climate is something that probably affects them there.
Mm.
I think the only other thing that sort of close to home here related to climate change, we know that Australia faced some pretty severe bushfires,
Absolutely.
over their
The
summer.
world
And
literally watched parts of Australia burn. Yeah.
yeah, so I think it's something that's very topical here within Australia as well. Australia's a pretty dry and hot place, and what is the future related to sort of a warming climate, and what will that mean to these sort of things? So I think it's fairly noticeable
Mm.
just here around the Pacific. We have different issues here. Ours was bushfires in Australia, and out there it's kind of like the inundation of seawater and what effects that's going to have. But places like the Solomons and low middle income countries, they're going to struggle because they're just not going to have the resources to say, okay, we'll move our lives back a little bit and rebuild everything, up in the hills. They don't have the resource to do that. So
Wow. So let's talk about TB and the work you did there in terms of your research. TB or not TB, I poke fun, but let's talk about the TB treatment study you did most recently in the Solomons.
yeah, so again, with this kind of communicable and non-communicable diseases there. TB is still prevalent. Malaria is a major
That's what we're going to
issue.
talk about next there too. Yeah.
And some of it is, how do you differentiate between what might be a more benign issue? Okay, not every fever is TB and not every fever is malaria, but with limited diagnostics and things like that, how do you figure this out?
Right.
And I think some of that TB or not TB paper is kind of asking that question, right? Are we over-treating or are we under-treating? How are we doing with our diagnosis, right? They do have some diagnostic capability there, but reagents run out and all these sorts of other problems they face make it very difficult to get an accurate diagnosis. And then if you don't have that, then your management is haphazard. And I think you're putting patients and populations at risk, both by over and under treatment. That's kind of where the TB or not TB is at. And I think it's just an issue across those Solomon Islands of determining what exactly are we managing here.
Yeah. No, that's for sure. And for those of you who regularly tune in to Stealth on Health, you'll know that 2 episodes ago we had Dr. Sheetal Verma, who did some really pioneering work in her TB laboratories, both back at Rutgers, and really was focused on some pretty unique transmission dynamics and protection against infection. So, this is something that may not be something that Americans certainly are aware of every day. We don't hear it on the news. We don't know people that get diagnosed with TB. But around the world, second to HIV, this is one of the leading infectious diseases.
Yeah, definitely. I mean, I think they still say the numbers are, it's in the billions, right? People with TB, whether that's active or latent or something like that. But it might be nearly 2 billion people who still have this. So it's very relevant to these populations. We know of it historically, but don't think too much about it. But if ever you go to one of these places, it very quickly re-enters your differential diagnosis list.
Wow, wow. So I want to talk to you a little bit about some of your ongoing and past work, which includes a focus on parasites, and certainly I want you to tell our audience a little bit about malaria. But it's very interesting that you brought up the example of World War II and a lot of American GIs that were traveling through the South Pacific, going through the Solomons and Guadalcanal and Bougainville. My grandfather, my maternal grandfather, actually was at the battles of Guadalcanal and contracted malaria. Now, when he was shipped back stateside, most physicians at the time that were not Army medics or certainly trained in the armed forces or in some of these tropical diseases didn't know what it was. And it wasn't until that he was shipped off to a medical center in Rochester, where a literally old timer from World War I, a physician who easily recognized malaria, they basically had fever of unknown origin. They didn't know what he had, and basically the physician came in and said, "That boy's got malaria," and certainly they wound up treating him and then sending him home. But you've got some ongoing work and some past work in the area of parasites. Tell us a little bit about malaria and parasites, and we've had an earlier program talking about parasites as well, so our viewers are certainly well equipped and well versed in the terms in vector-borne diseases. But tell us a little bit about your work.
Well, some of that work is, as we've been talking about, just on the ground stuff in
Yeah.
Kira, the Solomon Islands. There's a very high prevalence of malaria there, and every fever we must consider malaria, and even other stuff. So, there's probably a lot of people walking around with low levels of parasitemia, which might be asymptomatic for them because they've experienced it all their lives and they've built up some level of immunity. One of the things that we've found that's pretty interesting in the Solomon Islands, and in fact, I think we've just finally been able to publish something about this, is to say the two major parasites associated with malaria are Plasmodium falciparum and Plasmodium vivax, right? And falciparum is the one that scares a lot of people. It causes a lot of cerebral malaria, particularly deaths in children and things like that. And the numbers worldwide might be 500,000 deaths and things like that. That varies each year and is probably declining. But what we've seen out in the Solomon Islands is that although numbers quoted on sites like the CDC or whatever say, oh, you know, the Solomons probably has about 50% falciparum and 50% Vivax. On Makira, it's about 98% Vivax. So we think what we've seen is a epidemiologic shift through the use of the coartem, these artemisinin medications, which are very effective for falciparum. So we think we've seen quite a bit of eradication, actually, of the falciparum, but the Vivax just has a longer life cycle and has been more difficult to manage. And that's been an interesting thing. That epidemiologic shift has been reported in other places. And so as an on the ground, sort of in the trenches, that's part of my malaria experience. And then here at the Gold Coast in Queensland, we have two universities that are closely associated with our hospitals. And one is Griffith, where they have this Institute of Glycomics. And we're just one of a number of groups who are trying to create a malaria vaccine. You know, I am a journeyman of no particular expertise in
or destination
vaccinations. But it was sort of this opportunity came up years ago now. We've been doing this study since about 2013. Yeah. And I said, oh, I'm interested. I'll put my hand up and lend a hand and be a clinical supervisor within that space. And we've progressed on over these last 6-7 years. We are currently giving a trial of a malaria vaccine to healthy individuals and seeing if it prevents them from getting malaria. And over the last 2 years, we've shown that of 6 to 8 patients that we've given both the vaccination and then an inoculum of the malaria parasite, and again, this is the falciparum parasite, we've shown some protection with that.
Oh, wow.
With that.
That's promising.
Yeah, and it's going. There's stuff going on all over the world. Lots of reports. Lots of people want to get on top of this.
Yeah.
But because it's a parasite that changes itself throughout its cycle, even within the human host, it's been very hard.
So Jim, let's travel back in time together. A very young Dr. James Fink was once a hospitalist at Thomas Jefferson University Hospital. I don't know if you can remember it back that far. It's a very, very long time ago in a galaxy far, far away. And later you were promoted to director there. Tell us a little bit about what a hospitalist is. Tell us a little bit about how it's evolved in the time that you were still in Philadelphia, and also if you could add some thoughts on why it's so critically important today.
Okay. I think when I entered the hospitalist field, it was 8 or 10 years old in terms of the both the name hospitalist and what they were doing. And I think if you're an internal medicine doctor, traditionally you had a role both in an office setting, an outpatient setting, and in the hospital. And what the hospitalist changed was that there was a belief that it was hard to juggle those two things, outpatient and inpatient medicine. And so what they did was they kind of created this division, and they said, we would like to have doctors, internists, just work in the hospital where they think they can gain particular expertise as well as efficiencies in managing those patients. So that division occurred. Dr. Walker was one of the pioneers for that. But when I came into it in 2004 or so, it was growing rapidly and maturing. And I think it has continued to do so. I think the hospitalist group is now certainly a very legitimate group of carers for patients, and particularly relevant, I think, again, to the COVID crisis, is hospitalist services were probably managing most of the patients, not of a critical nature, not intubated, not needing ventilation and things like that within a hospital setting. So the hospitalist group made itself relevant in that way, given the current circumstances.
No, and so critically important today. I remember my first exposure to it once the Mayo Clinic descended on the Valley of the Sun out in Arizona, and when they opened up their hospital, I heard that term for the first time, and didn't know what those people were or where they came from, and certainly they were extremely hard to track down because they were literally within the framework of the hospital, and you needed to really try and find out who they were and track them down, and certainly find out how we could address some of their needs. And that was 99 and 2000. So certainly it has evolved over the time, and certainly an important part of the experience and the patient journey within the hospital framework. Jim, I want to get a little personal. Maybe get a little comfortable in that chair of yours there. I don't think I've ever asked you this. I think I may know the answer to the question, but what and who inspired you to become a doctor?
I think my father was a doctor and my mom was a nurse, and I think that they were inspiring examples for me. I even see, I just totally remember my dad, having neighbors kind of come by and, ask for his opinions, and he might listen to their chest and things like that. And I admired that. I guess I admired what he knew. And then on my mom's side, she was not doing her nursing as a profession during my early years, but she later went back after, her 4 kids had grown up somewhat, to sort of watch her do that and to see her care for people. I think these were inspiring examples for me. I mean, going back to the beginning of our conversation today, it was sort of like, what makes people go into medicine, and how are we going to continue to have those people go into medicine? I think there will always be, something in people's hearts that say, I want to do that. I mean, it is some combination of science. I enjoy the science, but I think I want to apply that to the messiness of the human condition, right? And I want to see if I can, do some good for these people. These are all reasons that, I think I chose to pursue it. And you read off that sort of dog's breakfast of a CV earlier about the kind of life's journey. I didn't get into medical school right away out of college, but it was something that I think I just kind of had this drive and felt like this was going to be the right combination of things for a life, right? I liked science, and I liked biology, and I liked, learning about, physiology and all those sorts of things. But then I also think, to those who much has been given, much is expected. And that's kind of, I feel like I've been given a lot. I think I've been pretty fortunate. I think it is partially my obligation to try and do some good.
No, and you certainly are. We didn't touch on this earlier, but and I don't recall talking about this recently. I know it was a couple of years ago. But is your foundation still in place for the Solomons?
Yeah. The Solomons has been something when I went into medicine, I still remember I'd gone to med school in Australia. Then I returned to the US and did my residency program in Oregon. And I remember telling the program director there, what do you want to do with yourself? And I said, I really want to ultimately try to help some people who are underserved, and maybe do some international care. And I didn't want to lie, so wanting to do something like the Solomons had always been in the back of my mind. And coming back to Australia after many years in the US, I just had this opportunity. So
Beautiful.
I've been able to do the Solomons as a project where we send final year medical students continuously to this one small 40-bed hospital in the Solomon Islands. So it's been sort of this clinical and academic pursuit, which has been
Perfect
fulfilling.
marriage. Yeah.
Yeah, and then the foundation, which you speak of, was just another layer, because I think when you're doing something as part of like a university and an academic institution, there are benefits and there are restrictions, and there were things that I saw and wanted to do that lay outside of the sort of purview of a university. So doing the Strong Island Foundation was just this opportunity to say, okay, if I branch out in that space, I might be able to have a little bit more freedom about doing other things. And one of those things, because Bond University, the university that I do the Solomon's project through, they don't have a nursing school or anything like that, but going out and doing the Strong Island Foundation, we've been able to create sort of a nursing exchange as well. And a place like the Solomons, and again, many low and middle income countries, they run on the backs of nurses. The doctor to patient ratio is about 0.3 to 1,000 or something like that. So nurses run these places, and they're essential and key in any health system, but even more so in that kind of place. Yeah. So that's kind of the story behind the Strong Island Foundation.
No, and it's certainly an inspiration and of the work that you are doing. Jim, I don't know the answer to this question either. What's your earliest memory of medicine?
Well, some of it might be, watching my dad literally listening to people's chests in the basement of our house. So there's that. I mean, there's just, or there was my mom, as me and my brothers would bang ourselves up and fall out of trees and bust our head open. She, instead of getting stitches in our head, she'd sort of tear together and glue together with some nail polish. So that was the way of closing wounds in the Fink house. There's some early memories of medicine. And then on a personal early memory, just from my own journey, I think for me, I was just so happy to finally get into medical school, and going from, which is always exciting for any medical student, you go from the preclinical to the clinical, and then you're finally like, this is what I've been waiting for.
So we wanted to take a moment and talk a little bit about your dad, some more, Dr. Joseph Fink, and his pioneering work in the laboratory. Can you talk about Dr. Fink?
My dad, a bit of a journeyman as well. I mean, he had a law degree and a medical degree, and did a lot of jobs within medicine. So he did his main role was in pathology and laboratory pathology, and included things like blood banking and stuff like that. And that's where he finished his career down at Columbia. But he had been all over the place. He had done some sort of family doctor type work earlier in his career. He had spent time as the corporate medical director at Becton Dickinson for quite some time doing that. So maybe I got infected with his, jack of all, master of none philosophy of life. But I've enjoyed that. And so I think when I think about my dad, those are the things that I admire. He was a very bright guy. I certainly don't think I match him in any way intellectually, but maybe I kind of come close to matching him in terms of my interest in the broad range of what's available in the medical field.
Yeah. And correct me if I'm wrong, isn't the laboratory at Columbia still named after your dad?
No, I do not think that that's the case. I
Oh,
think
okay.
that there, he did spend some time down there, but no, there's
Okay.
not nothing of
Excellent, excellent. So both you and your dad also had quite an unusual parallel life in your respective tenures. What was it like, as best you can tell, for him and certainly from you, to see this world from the patient's point of view?
Yeah. Well, I think my dad was always very good at understanding the human condition, and I think that my hope is that I am maturing and improving in that space. Um, my dad died in 2007. He had a lot of stuff going on medically at that time. He had fibrosing lung condition. He had a bit of a brain tumor. He had lots of things that you know led to his death. But I think he faced it all, pretty heroically and stoically.
Mm.
Um, and my opportunity to be in the bed and instead of at the bedside is that I've had, an acoustic neuroma removed. So I have no hearing on my right side
Mhm.
because with the tumor goes your eighth cranial nerve. The tumor unfortunately grew back a bit, and I had to get some radiation treatment and probably due for another MRI just to sort of see where we're at. Last check, which was about 18 months ago, things were pretty steady. But I do think it's a humbling and very good experience because I think in medicine, again, often spoken about, is we do lots of things to our patients or we tell them to do X or Y, and we don't quite understand what that all means. So it's good to be on the other end of it all and be getting those injections of anticoagulant as you sit in the bed, or wear those stockings, or have a intravenous infusion going in, stuff like that. I had post-operative complications, a bit of bleeding in my abdomen where they had removed a bit of fatty tissue, which they packed in my ear. So I had to go back to the theater. I ended up getting a little bit of a thrombophlebitis type of
Oh,
infection
my.
because of intravenous strips.
Yeah.
I was walking around with a drain, sticking out of my skin. But all of it is good, and I
Yeah.
think
Yeah.
I think that helps you to connect with patients in a more honest way. I think people can do it without these experiences,
Mhm.
but I think I'm grateful for mine because I do think it adds to that kind of sense of empathy.
Yeah. So, in talking about empathy, you and your family, we've talked about here in the show, and certainly in preparation for our discussion, recently had an incredible adventure moving to the UK and then back to Australia amidst everything going on with the
Hmm.
pandemic. Last we spoke, a couple weeks ago, you were actually in quarantine and
Yeah.
spent 14 days down in Melbourne in quarantine. Um, Dr. Fink, tell us about that experience.
It's an experience that I recommend against if it can be avoided. That's what I would say to people. So yeah, returning to Australia, there were a limited number of flights as the efforts to repatriate people, and so I got on a flight in London. It was one of these Dreamliners, which I'd never been on. I was very excited. And what they did was you had to wear a mask the whole time, and then they spaced you out on the flight.
Mm.
So this was a flight put on by Qantas, but also by the Australian government. Fly into Australia. It's a 17-hour flight coming from London to Perth. And then we sat on the tarmac for a couple of hours. We were not allowed to leave. They did a bit of a change of the crew and then flew into Melbourne, where the government again puts you up in a hotel quarantine. So this was 14 days. You get taken off the bus, you get sort of escorted, or sorry, you get off the plane, you get escorted onto a bus. The bus takes you to the hotel, and there you are.
Wow.
I was able to leave the hotel room for 10 minutes during those 14 days to
Wow.
go outside and get some fresh air. The hotel room wasn't too much bigger than this room I'm sitting in now. So yeah, it's tough. You don't want to whinge and complain about something like that. I absolutely understand why it's done, because the imported cases are the major concern in Australia. Absolutely. It's very generous of the government to do what they did. They feed you. It's on their bill,
Wow.
this whole expense. But being trapped in a room like that for 14 days, I did my best to have a schedule and study and read and do a little bit of online exercisey type stuff. But yeah, it wore on me.
Yeah, I can only imagine. And while we're not recommending this experience to anyone,
Yeah.
I do think that we do have a teachable moment here at hand in this part of our conversation. Certainly, as a young student at Scranton, you made the determination that you wanted to study biology. Any advice for those that are studying STEM related areas like biology and undergraduate programs right now?
Um, yeah, I mean, well, one of the things that's been interesting is during that quarantine, I was doing a lot of my own sort of just studying, right? It was not, I had plenty of time. And what I
And weren't
ended
going
up doing,
anywhere.
I wasn't,
It wasn't
no,
like you
yeah,
put lacing up the sneakers going for a classic run.
I was stuck. But
Yeah.
I ended up going on to YouTube
Okay.
and looking at all the kind of resources there. And they're amazing. I'm an old guy that we didn't have YouTube teaching available to us when we went through our undergraduates and even medical school or anything like that. It was textbooks and all the rest.
We had
The
that
research,
typewriter, if we were lucky, where you could
yeah,
delete the line before it printed.
STEM student,
Yeah.
one that might be aspiring to, medical school or something like that. I think that there's such amazing resources now that are both audio and visual, which I think is a great way to learn. So I think that those are there. I just think that and then just the accumulation of knowledge within this space of all of science is just amazing. And I think as a student, maybe as an undergrad, you're not interested in this, but I do think it adds to, um, a overall understanding is to understand a bit of the history of it all.
Mm.
Right. It was only within the last 2-3 years that I read Thomas Kuhn's, the what's his book? I forget now. I'm going to look silly, but knowing about the history and the philosophy of science, I
Mm.
think enhances one's knowledge in that space. So it's not that a STEM student needs to go in and do a great deal of reading in that area, but just to think about that and say, why is that term what it is, or where does that come from,
Mm.
and just the depth that
The
gives
origin
them.
story. Yeah.
Yeah, yeah, exactly.
Jim, we talked a lot about certainly a great number of topics here in our conversation today, but we haven't talked about your personal and professional goals right now. What would you love to accomplish next?
I'm still trying to figure out what I want to do when I grow up.
Yes, you do.
Uh, actually, I ask a lot of the junior doctors that exact question,
Yeah.
and some of them get nervous about it. But then I say to them, I'm asking you because I don't really know myself. I mean, I've had incredible opportunities, and now I've just literally returned to Australia, as you know, and I'm trying to think of what the next 5 and 10 years looks like. And in the last 5-10 years of my life, I've been able to combine a bit of clinical medicine, a bit of kind of managerial and leadership stuff, and then all these other various interests.
The dog's breakfast, as you so eloquently stated
Yeah,
earlier.
that's a very Aussie term, right?
Yeah.
It's dog's breakfast, but it has felt that way at times, and yet I have enjoyed it. I think keeping a couple of balls in the air keeps me motivated.
Yeah.
The question is how many balls, and if there's too many, then you're probably not doing things well enough.
Yeah.
And if you don't have enough, then for someone like me, I might get bored. So I'm literally having conversations at work right now about what's out there, what we think as a health system we might need to improve on, and how there might be a project that we can build in that space, and how I might be able to get involved. I'm definitely going to continue just working as a general physician, hospitalist. I have a particular interest in the sort of acute side of medicine. So in the last 2 years, I've gone back and just done a little bit of retraining in the ICU setting, just to feel like I was a bit better on that side of the equation, on the fast side of medicine rather than the slow side of medicine. Right. And so I sort of put it. And yeah, I think it'll be a combination of those things. And the work in the Solomons will continue, even though that's on hold right now as the world is sort of shut down. We'll see. I mean, I actually, I don't have a precise map of what it looks like. Yeah, at age 48, I got to say, okay, yeah, everything's a 2, 3, 5, 10-year kind of map, right? And I know there'll be pivots in that space, but I'll stay clinical. I will hopefully continue in some managerial kind of leadership positions and do the best I can.
Well, certainly on New Year's Eve 2020, none of us could have predicted we were going to be in the position we are now.
Yeah.
But on a deeply personal note, many of us have lost colleagues. We've lost family. We've lost friends. Some of us have seen the passing of public figures around the world, certainly that we admire. I don't know the answer to this question either, Jim, but have you lost anyone that you've admired during this unprecedented time? Who are they?
No, fortunately, no one of immediate family or even the extended family has been lost. There was, so my sister who lives down in Breezy Point in Queens, there's been some issues down there, and her daughter was affected with the sort of anosmia, can't smell type of issues.
Oh
but
wow,
she's
I was not aware of that. Yeah.
Yeah, so she had the classic kind of kids symptoms.
Wow.
But no, I've been lucky that no one that I've known very closely has been significantly affected. Over in Oxford, there was a couple of deaths amongst hospital staff. A couple of them were among maintenance staff. One was amongst one of the prominent nurses. But I was too new there, so I didn't really know any of these people. And then down here in Australia, I mean, as I say, things were relatively quiet. And so there's been no personal effects here either. I guess, yeah, lucky.
Very, very lucky. Jim, let me open up the floor to you for the final word in our conversation.
Oh, thanks for having me.
Thanks for waking up early to join me.
Yeah, now the sun has come up. You've watched it brighten behind me. It's now nearly 8 o'clock. No, thank you, Mario. This has been great. And watching your other, sort of stealth on healths, I think you've had a great group of people giving a real broad variety of just sort of opinions and expertise and stuff like that. I don't know if anyone's going to watch this and learn anything, but
we'll make sure they do. They're going to learn quite a bit.
Thanks for inviting me.
Yeah, my pleasure. And please send my regards to Jen and the girls as they wake up yet another day and the beautiful land down under. So thank you, Jim. Thanks for joining us. For the New Right Network, I'm Mario Nasinovich, and to access this episode and other on-demand programming from Celt on Health, I invite you all to visit newrightnetwork.com, the right voice right now. And thank you for tuning in. Stay informed and stay healthy.
Cheers.